Hello everyone. IPL. Yes, it's INI-CET Premium League. It's the time for IPL. Okay, but we are here for different IPL. T20 Aura. Yes, everybody is talking about IPL in India. Aura is there, but our aim is not that cup. Our aim this INI-CET IPL Premier League, which final take place on 7th May. That is the exam date. Okay, so we are prepared for that. I am coming to IPL INI-CET Premium League for you. Now, something about an academy mega extension offer on NEET PG subscription. You want this? You want this? Get free extension up to 12 months. Take this. Don't waste this opportunity. See the duration and what you need to pay. Come on this platform. Feel the difference. And this is IPL T20 top 20 topics of top educators. Yes, this is my class Pediatrics 2 Sanjay Khatri. So we are in the end of this session. You have attended all the wonderful classes of most of the educators, and this is for you. Last mile FMG preparation and pursue your ambition. Aim next and NEET PG. This two batch for you. FMG next oblique NEET. Be prepared. Come on this platform and feel the difference. Now straight we will go to some good topic about T20. Yes, IPL. Answer this question. Answer this question. Most important reason to carefully screening of Y chromosome material in patient with Turner syndrome. Turner syndrome karyotype is X0, 45X0. Most of the patient have 45X0. Few patients are mosaic, means most of the cells are 45X0. Few cell shows 45XI chromosome, isochromosome or R chromosome, ring chromosome. Okay, few cell shows 46XY, Y chromosomes. Most of the cells are 45X0. Few cell contain this Y chromosomes. If a Turner syndrome patient, you find Y chromosome material in few cells, that female is prone to develop gonadoblastoma. So this is our purpose. Carefully screen of Y chromosome material in patient with Turner syndrome. Turner syndrome is a female patient, 45X0. If you find few element of Y chromosome there, that female is prone to develop gonadoblastoma. So we can do prophylactic gonadectomy for that. This is clear. Turner syndrome, last to last year NEET PG, 2 questions. Last INI-CET, 1 question. And this is universal question. Answer. Microcephaly. You can't diagnose with microcephaly. Polydactyly, cleft lip, cleft palate. These can be feature for any syndrome, but the key feature is scalp defect, also known as aplasia cutis congenita. Aplasia cutis congenita. A neonate with microcephaly, small ear, polydactyly, cleft lip, cleft palate, but not forget scalp defect. If scalp defect is there, this is Patau syndrome. Yes, 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 you are right. You are right. This is Patau syndrome. Patau syndrome is trisomy 13. Trisomy 13. Can anybody put in the comment box classical feature of Edward syndrome with cleft lip, cleft palate, microcephaly? The classical feature of Edward trisomy 18 is overlapping of fingers. That is such a classical feature of Edward. You find a picture like this. Overlapping of finger. with cleft lip. Identify the syndrome. It is Edward syndrome. So no need to remember all the feature of Patau and Edward. Just remember Patau, it's trisomy 13. Edward, it's trisomy 18. Aplasia cutis congenita, scalp defect. What is this? This is scalp. In the portion you find absence of skin and hair. This is aplasia cutis congenita. Aplasia cutis congenita, scalp defect, and this is overlapping of fingers in Edward syndrome. So aplasia cutis congenita, holoprosencephaly, it's neuronal migration disorder. Microphthalmia, small eye, and polydactyly. These are the classical feature present in Patau. Microphthalmia, which syndrome? Patau syndrome. Overlapping of finger, hypertonia, and prominent occiput is a feature of Edward syndrome. So this is a classical question. Scalp defect in Patau. Overlapping of finger in Edward. I know you know this. It's just revision from my side. Revision from my side. Rocker bottom foot, my friend, dark night is also present in Patau. It's not classical of Edward. Rocker bottom foot can present in both, but overlapping of finger in Edward, prominent occiput in Edward, hypertonia in Edward, because hypotonia is a feature of trisomy. Like scalp defect, small eye, holoprosencephaly is in Patau syndrome. So just remember these specific feature to crack Edward and Patau. Hope I am clear in this. Answer this. Try to answer. All of the following associated with increase in the severity of HMD. HMD, a classical question for INI-CET. Yes, HMD is due to deficiency of surfactant. Now, maternal hypertension. In maternal hypertension, circulating steroids are more. And what steroid does? Steroid increase surfactant. So maternal hypertension is not a risk, even it is a protective phenomena. Maternal diabetes mellitus. If mother is having diabetes, increase glucose from mother goes to baby. Baby, in response to high glucose, Iceland of Langerhans hyperplasia occur. So there is more insulin. Insulin decrease surfactant. So infant of diabetic mother, maternal diabetes is a risk factor. Decrease gestational age is a risk factor because first I will explain you. Surfactant produced in type 2 pneumocyte. Surfactant produced in type 2 pneumocyte. It reaches on lung surface at 20 weeks. In amniotic fluid, 28 to 32 weeks. Mature at 35 weeks. So you got it. If any baby born before 35 week, risk for HMD is there. So lung will be immature. And these are the hormones. Steroid and thyroxine increase the surfactant. Insulin decrease the surfactant. So these are the risk factor for HMD. Increase risk when baby is preterm. Increase risk more in 28 weeker than 32 weeker. More in 32 weeker than 34 weeker. Prematurity is an increased risk. Male sex incidence wise, female babies are strong. Maternal diabetes, increased risk. LACS, increased risk. Parental asphyxia, increased risk. Because of hypoxia, surfactant protection is decreased, and multiple gestation, again a increased risk. Just remember, maternal diabetes is an increased risk. Decreased risk, the most important, maternal hypertension. Why? When mother is having hypertensive, circulating steroid in the bloods are more. When steroid more, it increase surfactant. PROM, premature rupture of membrane, leads to stress-like activity, more steroid in the body. So these are decrease, these are increased risk. Come to the question. Increased risk, maternal diabetes, decreased gestation age, male baby. PROM, it's protective. Maternal hypertension is protective. So what are the increased risk factor? 2, 3 and 4. So where is 2, 3 and 4? Anybody? Yes, dark night, Sindhuza. Sindhuza, you put D. Okay. So got it? Increase and decrease risk factor for HMD. HMD, you find frequent question in exam. Yes, it is one of the most important topic when you are preparing for exam like AIMS, HMD. Now, classical. How you diagnose HMD? This is X-ray. If this is alveoli, surfactant keep the alveoli open. Surfactant keep the alveoli open. Surfactant keep the alveoli open. If no surfactant is there, so what happen? If no surfactant is there, there is white out appearance. Okay, so this is not working. So lungs are, give me one more minute. So whole lungs are white. Collapse, white out. Suppose you imagine you are writing on a blackboard, chalk in your hand, you rub the chalk from top to bottom. Homogeneous white. This is ground glass appearance, present in severe form of HMD. In white lung, you find black dot. This is fine reticular pattern. This is moderate form of HMD. In a lung, you find black slit-like opening. This is air bronchogram. This is present in mild form of HMD. Mild, moderate and severe form of HMD. Chest X-ray shows mild, moderate and severe form of HMD. Mild form, air bronchogram. Moderate, fine reticular pattern. Severe, ground glass appearance. Clear? Clear? So this is by X-ray. Any other thing? Lecithin sphingomyelin ratio in amniotic fluid. Normal, it is more than 2:1. If ratio is less than 1.5:1, it indicate lung immaturity, and these all questions were asked in previous exams. In our days, X-ray take long time. Okay, so radiographer came to the nursery, they take the film, then film goes to the dark room, they dry it take a long process. But now my uh, doctor posted in nursery, just send me the X-ray before the class of a baby. They came, they took the X-ray. You can take the photo from your mobile, X-ray. They give you the X-ray on your computer in a less than 1 minute. You get the X-ray. So whenever baby is sick, now X-ray is easy bit. Our day, it take long time. But baby is preterm and we want to know whether it's HMD, yes or no, lungs are mature or no. So then one test is there, shake test. We put a nasogastric tube or orogastric tube, take the gastric aspirate in the test tube. Add alcohol in this and then shake. If bubbles are forming, rim of bubbles are formed, lungs are mature. You are shaking. No bubbles are forming. Shake test negative. It indicate lungs immature. Risk of HMD is there. So sometimes they ask you, shake test is used to assess maturity of lung, heart, gut, brain. Shake test is used to assess maturity of lungs. Clear? Clear? Now, this is the classical question. Vectral. Vectral. Asked in PGI so many times. Vectral. What is V? What is A? What is C? C is cardiac defect or cleft palate. V is okay. A is okay. What is C? TE, tracheoesophageal fistula. What is R? Whether it is retinal or it is renal. You will be confused, na? So yes, we should know everything about vectral and its associated syndrome. See here, this is vectral. Vectral means V for vertebral defect, A for anal atresia, C for cardiac, it's not cleft palate, TE for tracheostomy fistula, R for renal anomaly, it's not retinal detachment, and L for limb abnormalities. So come to our question. Yes, this is vectral, this is vectral, and this is vectral. 1, 2, and 4. Yes, yes, yes. So many. Dr. Shubham Gupta, Jiten Yadav, Sadhna, Deepak, DK Knights 08, all are putting D. I am happy. But something you know about tracheoesophageal fistula. What is the presentation? What are the type? How it manifests? See this question. See this question. Read this question. Trust me. Vectral, charge, tracheal fistula, coinal atresia. These are typically made question for AIMS and PGI, now known as INI-CET. A neonate with respiratory distress and excess frothing from the mouth brought to emergency on day 2 of life. Frothing and respiratory distress, life 2 day of life, and mother is having history of polyhydramnios. So all the points connected. Why mother is having polyhydramnios? Baby not able to swallow amniotic fluid. Baby not able to swallow amniotic fluid. Baby not able to swallow amniotic fluid. So baby not able to swallow amniotic fluid. Why? This is the problem. Esophagus, upper end of esophagus is blind, lower end is connected to trachea. So this is tracheoesophageal fistula. Upper end of esophagus is blind, lower end is connected to trachea. Tracheoesophageal fistula. Okay, frothing, respiratory distress, mother is having history of polyhydramnios. Now see what happened. 2 days old baby or 1 day old baby in nursery. So generally a protocol when you are posted in nursery, need to do stomach wash. Stomach wash, remove the some maternal secretion which baby take inside during delivery out, and ensure patency of esophagus. You do the, as you try to do the stomach wash, you push the nasogastric tube and it's not going. It's curl here. It's not going. No problem. Call the nursing staff. Sister, I try, but I feel it's not going. They are very experienced. You need to respect their experience. No, doctor, it's not going. Don't push it. Get a X-ray done. In X-ray, you find nasogastric tube is curved here. Okay, so diagnosis is sure. Tracheal fistula. Call the pediatric surgeon. It's an emergency. Child need to operate it in odd hours also. Tracheoesophageal fistula. This surgery is going on since last 25-30 years with a good efficacy. Good, wonderful result. But you need to diagnose it properly. Tracheoesophageal fistula. Second condition. Read this question. Try to make an answer. Try to make an answer. Yes, he will survive, my friend. Definitely. I have seen recently last week a 20-year boy for ASD. Parents told me operated for tracheoesophageal fistula in 2002. Wonderful. No complaint were there. Yes, dekh lenge. Now, see this question. If cyanosis increase when you feed the baby classically, and if cyanosis decrease when baby is crying, this is the classical of corneal atresia. See, as when they attempt to feed the baby, oxygen level drops into 60s. When you feed, level drop into 60s. Corneal atresia, you are feeding where respiration take place. Got my point? When you stimulated and baby cry, saturation leads to 90s. This is classical of corneal atresia, and this is the typical question. If you are suspecting you're dealing with this type of history, what you will do? Passage of catheter into the nose. Passage of catheter into the nose. Passage of catheter into the nose. Tracheoesophageal fistula. Corneal atresia. Clear? Clear? Charge. Corneal atresia is a component of charge. Like tracheoesophageal fistula is one of the component in vectoral. So next time you get a question, all are true about charge except C. It's not cleft palate. C is coloboma. So you are posted in nursery and you diagnose this corneal atresia. You call the ENT surgeon or pediatric surgeon. They will ask you one question. Doctor, it's a isolated corneal atresia or it's a part of Char syndrome? You know this question. Before they come, you get a eye checkup done. Coloboma is there? Yes or no? Echo done. Heart defect there? Yes or no? Check the anal patency. Anal atresia. Anal atresia. Corneal atresia. Corneal atresia. Retarded growth. See the genital. Any abnormality or any ear anomalies. Look for this. Look for this. You got my point? You got my point? So you are mentally prepared. Suppose NG tube is not going. It's curl. It's a tracheoesophageal fistula. The same question pediatric surgeon will ask you. Doctor, is isolated tracheoesophageal fistula or it's a part of vectoral? So you done the spine X-ray, vertebral anomaly. So all these things, the component charge and vectoral, you should remember. I will stuck here for 30 seconds. Remember, vectoral, V, vertebral defect, A, anal atresia, C, cardiac defect, TE, tracheoesophageal fistula, R, renal anomaly, L, limb abnormalities. Charge, C. Coloboma. H. Heart defect. Atresia corneal. A. Retarded growth. Genital anomaly. Ear anomalies. Ear anomalies. In charge. I is ear anomalies. So just it take 30 seconds. You write previously when PGI exam is different. You find charge and vectoral so many time in their papers. INI-CET one is PGI only. So this vectoral and charge should be on your tips. Answer this question. 9-year-old boy is steroid dependent nephrotic syndrome. What is steroid dependent nephrotic syndrome? Once you start steroid, patient respond. Patient respond. Okay. But once you stop steroid, Within 14 days, within 14 days, urine again positive for albumin. It means that patient need steroid for longer time. Once you stop steroid, urine again contain albumin. Need steroid for 9 to 18 months. It's not easy to give steroid to 9 to 18 months. Steroid has its own side effect. Some patient developing blood pressure, hirsutism, cataract, cushingoid features. Steroid can cause. So, is there other alternative steroid? In steroid dependent nephrotic syndrome, there is a newer guidelines. Comes in late 2022. It may be a question for INI-CET. Frequent relapsing or steroid dependent nephrotic syndrome. Frequent relapse, patient is on steroid more than 1 milligram per kg. Now the key point, steroid toxicity. No. Patient is taking steroid for 5 months. Till now, no toxicity developed. If you want to switch to other drug, other is levamisole is the drug of choice. Levamisole is the drug of choice. Patient is on steroid for 5-6 months, but steroid toxicity develop. No choice, you need to stop the steroid. Then drug of choice is cyclophosphamide. 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 You can give mycophenolate mofetil MMF, but drug of choice is cyclophosphamide. Easily available, less costly. Okay, so simple. Steroid dependent nephrotic syndrome. If toxicity develop, cyclophosphamide. No toxicity develop, you want to shift to other drug, levamisole. These days, people are using levamisole so frequently. So see this question. Steroid dependent, toxicity develop, then you have no choice. You need to give cyclophosphamide. And this is newer guideline. INI-CET fond of giving the question which contain new guidelines. This is the newer guidelines. It's clear. Cyclophosphamide. Answer this question. Good question. Coca-Cola color urine, beta hemolytic streptococci, complement C3 is very low, 15, C3 normal is 100, but here it is very low, very low. So you know it's post-streptococcal glomerulonephritis, but some dilemma in the diagnosis. Only best thing, C3 level is low. But if you want to confirm your diagnosis, learn one thing. In post-streptococcal glomerulonephritis, C3 is low. What are the other conditions in which C3 is low? These are the other conditions. C3 level low in lupus nephritis, membranoproliferative glomerulonephritis, post-streptococcal glomerulonephritis, mixed essential cryoglobulinemia, and glomerulonephritis associated with endocarditis and shunt nephritis. Now listen the key point. In post-streptococcal glomerulonephritis, C3 is transiently low. C3 is low, transiently, normal in 8 to 10 weeks. So you have a dilemma whether it's a post-streptococcal or no. You can repeat C3 level after 8 to 10 weeks. Initially it was 15, but if it's a lupus nephritis or membranoproliferative or glomerulonephritis associated with endocarditis or shunt infection, C3 will remain low. 15, 15, 15, 15 will remain low. But if it's post-streptococcal, it become normal in 8 to 10 weeks. So, in order to confirm your diagnosis, suspected diagnosis, when would you like to repeat C3? In 8-week time. Clear? Yes, if low in 8 week, renal biopsy indicated. Low in 8 week, it means you are not dealing with post-streptococcal, it's low, then it may be lupus nephritis, membranoproliferative glomerulonephritis. Answer will come from renal biopsy. Yes, Arun Sharma, perfect. Got my point? C3 level. Now your stage is not like that. What is the diagnosis? Post-streptococcal glomerulonephritis. The typical question. INI-CET. Yes, and we are doing good 2020 topics. Answer this. Universal question. Take your time. I want few of you will put in the comment box correct answer. Then we will finish jaundice in another 5 minutes. I receive so difficult one. Okay, let's read jaundice first. Meanwhile, you are keep writing your answer. Now see, look here. Oh, so many people are answering. Old RBC and iron containing enzyme. After destruction of old RBC and iron containing enzyme, hemoglobin produced. 90% hemoglobin produced from old RBC, 10% from iron containing enzyme. This hemoglobin in the presence of heme oxygenase enzyme convert into biliverdin. This biliverdin in the presence of biliverdin reductase convert into bilirubin. This bilirubin is bound with albumin. And this bilirubin enter into the liver. Till here everything is clear. Old RBC with its half-life destroy, liberate hemoglobin in the blood. Iron containing enzymes, MAU, catalase, peroxidase, when they degrade, release hemoglobin. Hemoglobin will convert into biliverdin and biliverdin convert into bilirubin. Liver, this is unconjugate bilirubin. In the presence of gluconyl transferase enzyme, it convert into conjugate bilirubin. If it is not able to convert into conjugate bilirubin, it will not able to excrete in the bile. Once it convert into conjugate bilirubin, it excrete into the bile. Got my point? Now what happened? Once it enter into the bile, and this is conjugate bilirubin, it reaches to intestine. This is conjugate bilirubin. This conjugate bilirubin is acted upon by bacteria, which convert conjugate bilirubin into urobilinogen, stercobilinogen. Urobilinogen via urine, stercobilinogen via stool, out from the body. This reaction from old RBCs to urobilinogen in urine and stercobilinogen in stool occur in our body every day, every hour, every minute, every second. Old RBC is destroyed and finally bilirubin, which is out from the body. Clear? Now very good, 2 MCQs, or I say one clear MCQ. If 1 gram hemoglobin degrade, how much bilirubin produce? 35 milligram. Suppose neonate has a hemoglobin of 16. If it become 15 due to hemolysis, 35 milligram bilirubin released. 35 milligram bilirubin released. Clear? Now watch this whole in a single page. Old RBCs, iron enzymes, hemoglobin, bilirubin enter into the liver, acted upon by gluconyl transferase, which convert into conjugate bilirubin. Conjugate bilirubin comes into gut, acted upon by bacteria, convert it into urobilinogen and stercobilinogen. Urobilinogen from urine, stercobilinogen from stool, out. Simple, simple. Na? Now you can understand when when jaundice occur, if any imbalance in this, if imbalance occur before conjugation, jaundice is unconjugated hyperbilirubinemia. Once bilirubin is conjugated, then jaundice occur. It called as conjugated hyperbilirubinemia. Simple. I'm not going in detail because it's not a final MBBS class. It's you are preparing for INI-CET. Now see, when more hemoglobin produced, if more hemolysis, hemolytic anemia, ABO-RH incompatibility, more RBC breakdown, more bilirubin will form. Decrease uptake by the liver. Liver is not taking the bilirubin in. So how bilirubin get conjugated? Third, problem in conjugation. Problem in conjugation. Problem in conjugation. What are those problems? See, first, syndromes. Second, others. Syndromes, CN type 1, Klegler-Nazar type 1, Klegler-Nazar type 2, Gilbert syndrome. Other is more important. Put star over this. Others are more important. First two are very clear. Hemolysis, RH and ABO incompatibility. Hemolytic anemia. Decrease uptake by the liver. When liver refuses to take bilirubin. When there is a sepsis or acidosis. Decrease conjugation. One is syndrome. Other is hypothyroidism. Breast milk jaundice. Hypothyroidism. Breast milk jaundice. Here is the key. Why jaundice occur in hypothyroidism? Listen. This is the enzyme gluconyl transferase. Its normal activity. For its normal activity, it require normal level of T3 and T4. If T3, T4 low, gluconyl transferase will not mature. So unconjugate will not able to convert into conjugate. Simple, na? That's why hypothyroidism leads to unconjugated hyperbilirubinemia, because this enzyme is not mature in hypothyroidism. So unconjugate bilirubin is there, not able to convert into conjugate, spill into blood. So hypothyroidism there is, unconjugated hyperbilirubinemia. Now breast milk jaundice, other breast milk jaundice. What happened in breast milk? Breast milk contains a substance known as pregnenolone. Pregnenolone. This pregnenolone inhibit enzyme gluconyl transferase. This pregnenolone inhibit enzyme gluconyl transferase. Baby taking breast milk, gluconyl transferase depress. Unconjugate will not able to convert into conjugate. Unconjugated hyperbilirubinemia. So these three headings are clear to you. Increase hemolysis, decrease uptake by the liver, decrease conjugation in the liver. Fourth heading, factor which increase enterohepatic circulation. What is this? Factor which increase enterohepatic circulation. Listen carefully. When conjugate bilirubin reaches to the gut, it's supposed to be acted upon by bacteria. But some condition when gut flora is not developed, like fasting, meconium ileus, pyloric stenosis, nothing is going into the gut. So gut flora is not developed. One enzyme is there in gut known as beta glucuronidase. Now bacteria is not there. This is very honest enzyme. It says to act on conjugate bilirubin, first right is of bacteria. If bacteria is not there, so beta glucuronidase convert conjugate bilirubin into unconjugate bilirubin, and unconjugate bilirubin absorbed from the gut lumen reaches to liver. This is known as enterohepatic circulation. What we are suspecting, conjugate bilirubin convert and it should be goes out from the body by circumbilinogen and urobilinogen. But here conjugate bilirubin convert into unconjugate and again reaches to liver via blood. So factor which increase enterohepatic circulation, prematurity, pyloric stenosis, fasting and meconium ileus. What are the causes of conjugate bilirubin? Once bilirubin is conjugated, this is conjugate bilirubin. Conjugated. The problem start after conjugation. See, syndromes, Dubin-Johnson and Rotor syndrome. Dubin-Johnson and Rotor syndrome. What happened in these? This conjugate bilirubin is there but is not able to enter into bile duct. Dubin-Johnson and Rotor syndrome. Metabolic disease of liver, any disease you remember, galactosemia, fructosemia, all leads to conjugate hyperbilirubinemia. And last, obstructive biliary atresia. Very easy to remember conjugate hyperbilirubinemia. Dubin-Johnson and Rotor syndrome, metabolic disease of liver, and obstructive causes. Unconjugated, increase hemolysis, decrease uptake by the liver, decrease conjugation, in which 3 syndrome and 2 others. Others, hypothyroidism, breast. Then factor which increase enterohepatic circulation. Conjugate hyperbilirubinemia, syndromes, metabolic disease of liver and obstructive causes. Come to the question. All are the causes of unconjugated hyperbilirubinemia. Hypothyroidism, breast milk jaundice, right. It's not galactosemia. Gilbert is right. It's not Rotor syndrome. I am happy most of you put it right. That is D, 1, 2 and 4. PGI, always one question on jaundice. Okay, INI-CET, you may expect. Got it? Unconjugated, conjugated hyperbilirubinemia. I hope we started from the basic whole metabolism of bilirubin, how the unconjugated and conjugated. Am I clear in this? How, why jaundice is there in hypothyroidism and breast milk, unconjugated hyperbilirubinemia? Clear? Answer this question. If all are clear in jaundice, please put OK or give thumbs up. No, huh? Putting a thumbs up, yeah. Now, this is the question. A 6-year-old boy, generalized tonic-clonic seizures, multiple episode in last 36 hours. Seizures control with 2 anti-epileptics. Since the child had seizure, child not able to speak, else oriented with the surrounding. Sudden loss of speech with seizure disorder. Sudden onset aphasia. Sudden onset aphasia. Sudden onset speech disorder with seizure. It's a part of Landau-Kleffner syndrome. Sudden loss of speech. Sudden aphasia. Sudden loss of speech is a feature of Landau-Kleffner syndrome. Remember, typical INI-CET questions. So what are other things? What is West syndrome? Asked 2 times, once in AIMS and 1 time NEET PG. West, it's a triad of epileptic spasm, plus neurodevelopmental regression, plus EEG shows hips arrhythmia. West syndrome common between 2 to 12 months of age. Infantile spasm was gen mode old term. Old term. Now the new term is epileptic spasm. Same thing. Epileptic spasm. Epileptic spasm. Okay. Lennox-Gastaut syndrome is nothing much to remember. It's a multiple seizure abnormal EG developmental delay. So non-specific. Landau-Kleffner, multiple seizures with sudden aphasia. So just remember West syndrome and Landau-Kleffner syndrome. They can ask. Aha, very good question. Yeah, dark night ACTH is the drug of choice to control seizure, to control epileptic spasm. Yes, Sahu Patil also authenticated. Now, which of the following is a correct match? Go for it. I will teach you, but first you try. Okay. First we go with the symptoms, features, then we come to the choices. Because why I am putting this type of choices? You get more text to remember and little bit trick. This type of question may come in your exam. So, basic, triad of rubella. Triad of rubella. Deafness, cataract, CHD. Triad of rubella, deafness, cataract, and CHD. Triad of toxo, chorioretinitis, diffuse cerebral calcification, hydrocephalus. Triad of toxo, chorioretinitis, diffuse cerebral calcification, hydrocephalus. Clear? CMV, remember periventricular calcification. And congenital varicella syndrome, cerebellar hypoplasia, and the most important, limb hypoplasia. You get a limb hypoplasia. These all are traditional. We are reading for so many years. This is new edition, new Nelson. Parvovirus. If mother is having parvovirus, non-immune hydrops fetalis occur to baby. Mother is having HIV, baby also having HIV, having feature. Severe thrush, failure to thrive, calcification of basal ganglia. If mother is having Zika virus, baby will have microcephaly, lysencephaly. Lysencephaly means smooth brain. No sulci, no gyri. Cut section, smooth brain. Cerebellar hypoplasia, subcortical calcification, retinal mottling, macular scarring. Means classically, lysencephaly occur in the baby if mother is having Zika virus. I have, Jan Mode, search the YouTube. I have one video, career in pediatrics, and I am touch all the prospects if you do basic pediatrics and if you go to the super specialty pediatrics. If I can again make, but if you search, you find this in YouTube. Now, toxoplasmosis, diffuse cerebral calcification, it's not periventricular. Congenital varicella, limb hypoplasia, it is right. Zika virus, lysencephaly, it is right. CMV, no cataract is there. Rubella, deafness is there. So correct answer is 2, 3 and 5. 2, 3 and 5. C is right. Yes, something you will get from this, but basically my target in this INI-CET, because questions are little higher level. INI-CET. Okay, it's very easy for me to say yes, but yeah, it's mainly targeting INI-CET. Answer this question. Answer this question. 1 year male weighing 6 kg, presented with loose motion. On assessment, child is irritable and thirsty. Irritable and thirsty means child is having some dehydration. Some dehydration, we use the plan B. Plan B is weight into 75 ml ORS in 4 hours. Weight into 75 ml ORS in 4 hours. What is the weight of the child? 6 kg into 75 ml ORS. 6 into 75. 6 into 75. Answer would be 450 ml ORS. Clear, na? Clear. Just you need to multiply. First, you need to identify it is no, some, or severe dehydration. By irritability and thirst, you can identify it is some dehydration. When some dehydration, you need to use plan B. What is plan B? Weight into 75 ml ORS in 4 hours. So it will come 450 ml ORS. Okay. We will cover plan A and plan C also. But yeah, in this question, you need to pick irritable and thirsty. An amount of ORS in first hour is 450 ml. Answer this question. 2-year, 5.5 kg male. Child is having loose stool since last 3 days. On examine skin pinch, skin goes back in few seconds. So how can we identify, how can we grade dehydration? When child with loose stool, loose motions comes to us, our first aim to assess degree of dehydration. To assess degree of dehydration. Because treatment based on that. If child is having no dehydration, plan A. Child is having some dehydration, plan B. Child is having severe dehydration, plan C. So here is the thing. Assessment of dehydration. You read this for 30 seconds. I am still want to see a paper which is not contain a question on diarrhea and PM. Pediatric paper always contain a question of diarrhea or PM. Look this table for 30 seconds at least. Assessment of dehydration. Dehydration is either no, some, or severe. Mild, moderate dehydration terms no longer used. Dehydration is either no, some, or severe. So how can you assess? Concentrate on these 2 points. Child is irritable or child is thirsty. It is some dehydration. See this. Child is lethargic, not taking anything, not able to drink. It's severe dehydration. Child is having loose stool, but well alert, not thirsty, playful. It's no dehydration. So the most important, irritable, some, lethargic, severe. Thirsty, some, not able to drink, severe. So these are the key. These are the key. Other points are also there which can help you. What are those points? Look at the eye. Eye look normal, it's no dehydration. Eyeball shrunken, some dehydration. Very shrunken, severe dehydration. Skin pinch. If you pinch skin, goes back slowly, some dehydration. Very slowly, severe dehydration. Tongue and mouth, dry, some dehydration. Markedly dry, severe dehydration. So we can't understand this. These are the subjective finding. If I feel skin goes back slowly, you feel it's going very slowly. I feel eyeballs are markedly shrunken. Mother told its original eyeball is like that only. So these are the subjective finding. So these can help, but we can't trust these. The trustworthy findings are irritability and thirst, some dehydration, severe lethargic, not able to drink. Come to our question. Come to our question. Child is having loose stools since last 3 days. Skin pinch goes back in few seconds. So what we can write? This question was asked to me by the student when they came from the exam. This was the AIMS question. So those write, sir, their logic. Only skin pinch is given. Nothing is given. Goes back in few seconds. We can't count the seconds, sir. That's why we write some dehydration. Other group. Skin goes back in few seconds. Means it's more than 3 seconds. So it's severe dehydration. So when I read the question, there is a clue. Child is 2 years. Weight is 5.5 kg. 2 year, what is the normal weight? 2x plus 8. 2 into 2 plus 8, 12 kg. What is the weight of the child? 5.5 kg. Means less than 50%. Less than 50%. So child is having severe PM. When child comes with severe PM, assessment of dehydration signs change. Assessment of dehydration sign change. Assessment of dehydration in severe PM. Signs which are not useful. Signs which are not useful. Skin turgor. In severe PM, skin turgor is always delay. If the child is dehydrated or not. Dryness of oral mucosa. In severe PM, salivary glands are atrophied. So mucosa is always dry, and mental status. When you read kwashiorkor child is always dull. Marasmic child is always irritable. By looking at the child, irritability or dullness, you can't comment dehydration in severely malnourished child. Signs which are not useful. You are in the night duty. The same 1 year, 2 year old, 5.5 kg, loose motions. They want to know which signs are useful. How can you assess? So just remember, thirst is always a sign of some dehydration. This baby is thirsty, it's some dehydration. Some dehydration. Okay, feel the pulse. If you are not able to palpate the pulse, it's severe dehydration. Ask the mother, child passed urine since last 6 hours. Mother says no urine since last 12 hours. Severe dehydration. So signs which are not useful in assessment of dehydration in severely malnourished children: skin turgor, dryness of oral mucosa, mental status. Signs which are useful: thirst. If you feel thirsty, some dehydration. Pulse and urine output. And this is very important question in previous aims. 2 year, 5.5 kg, only skin pinch. Skin pinch in malnourished. You can't comment. You can't comment, na? Because skin turgor is delayed in severe PM. So correct answer would be can't assess. All are very happy. If my wrongs, they are also wrong, na? So if answer would be some or severe, na, one group is very happy, one group is sad. When answer is D, nobody write D. All are happy, my friend. It's a life. Take it as it comes. Not afraid, not afraid. Okay. So yes, these two classes. First, yesterday, if you miss, go and again watch. And second one, today. Yes, it's IPL T20. Are you watching T20 matches? Okay. Next season you can watch. This time concentrate on this. Very fast game. Moving so fast. Can't afford any time weakness. Player, captain who plays smart based on the situation will win the game. That's you. That's you. Read smartly the topic which are important for INI-CET. We as Unacademy educators are there to help you. Just trust on us. Read those topics which are important. Like T20 player, play smart. You read smart. Read smart. Okay, divide your days. Be strongly. You know na, Captain Cool. Yes, if you remain cool and calm during study, success will be yours. So myself, Dr. Sanjay Khatri, signing off this IPL 2 classes. I hope you enjoy this. Share with others if you like. All the best from my side. You all do well. Thank you. Bye bye.